Very good afternoon. Uh, we all have assembled here after the lunch, after a really refreshing lunch. Thank you for that. So the post-lunch session begins with a interesting talk from Dr. Rajesh Jamolkar. He is a distinguished medical educator and a biochemist and an associate professor in the Government Medical College, Jalgaon, Maharashtra. Acha. Dr. Jamolkar brings over 12 years of teaching experience and exceptional expertise in the field of medical education. And he has impressive credentials, teaching both MBBS, MD, and DNB in biochemistry. A prolific author of two important books, that is Case-Oriented Approach in Biochemistry and Biochemistry Rapid Revision Handwritten Notes. Please share us also the books, okay? And his work has been recognized as the best author book for award by the 5th National Editors Summit 2023 by the Innovative Education and Scientific Research Foundation of India. And there are so many. And he's also a guest faculty for the NEET PG platform. So I think he will tell us something about the next also, the next exam. So over to you, Dr. Jamolkar. Please continue your talk.
Hello all respected dignitaries, my senior colleagues, senior members of the biochemistry and other faculties also. बायोकेमिस्ट्री कैसे पढ़ा है ये तो मैं आप लोगों को नहीं पढ़ा सकता, क्योंकि आप लोग मतलब ये जो फील्ड है इसके बाप लोग बैठे हो आप सिंपल वर्ड में, और मैं एक छोटा सा पैदा हूँ और ऐसा कुछ मैंने बहुत बड़ा कुछ किया नहीं है. आई हैव वन यूट्यूब चैनल फॉर द एक्सीडेंटल यूट्यूब चैनल. एक्सीडेंटल वर्ड इज इम्पोर्टेंट क्योंकि एक साल मैं सिलेबस कंप्लीट नहीं कर पाया और मैंने वो एक्सीडेंटली या वो यूट्यूब पे डाल दिया जेनेटिक सीरीज और वो हिट हो गया. नाउ आई एम हैविंग द नियर अबाउट 5 लाख सब्सक्राइबर्स ऑन द यूट्यूब एंड और इसी चक्कर में आई एम हियर फॉर द डिस्कशन. इसी चक्कर में ना एक फर्स्ट ईयर का टॉपर बच्चा था, वो बच्चे ने वो यूट्यूब पूरे चैनल के वीडियोस देख के नोट्स बनाए. फर्स्ट ईयर का टॉपर का बच्चा, जेएमसी नागपुर का, मतलब बच्चा टॉपर था फर्स्ट ईयर में. और हमने डरते डरते उसके 50 कॉपी प्रिंट करने के लिए मैं गया, तो वो प्रिंट जो पब्लिशर था वो बोल रहा था नहीं सर 50 तो नहीं कर सकते, पूरा था नहीं हमको एंड कॉस्टली, सब ब्ला 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 किया उसने. तो डरते डरते हमने 100 कॉपीज प्रिंट किए. तो वो 100 कॉपीज जो प्रिंट किए वो भी हिट रहे, तो उसको काफ़ी अच्छा रिस्पांस था. और नेक्स्ट 2-3 साल में कम से कम 16-17 हज़ार कॉपीज उसके अमेजोन पे सेल हुए. नाउ इट इज प्रिंटेड एज 3rd एडिशन इन द जेपी पब्लिकेशन. नाउ इट इज विद द जेपी पब्लिकेशन, हैंड रिटन नोट्स. तो मैं कभी भी बच्चों को नहीं बोलता कि सिर्फ आप नोट्स पे डिपेंड रहो. मैं हमेशा बोलता हूँ कि स्टैंडर्ड टेक्स्ट बुक पढ़ो और उसके साथ एग्जाम के लिए नोट्स पढ़ो. लेकिन बच्चे कभी हमारा सुनेंगे तब ना, वो डायरेक्ट नोट्स पे जंप कर दे. तो मुझे फैकल्टीज के तरफ से भी काफ़ी गालियाँ मिलती है कि ये मतलब इजी कर दिया और बच्चे अभी स्टैंडर्ड टेक्स्ट बुक नहीं पढ़ते एंड ऑल. एंड अभी सोचो फर्स्ट ईयर में बच्चा, मतलब अभी कोई पेरेंट्स होगा उनका बच्चा भी मेडिकल में होगा, तो वो जब एंट्री करता है मेडिकल में तो उसके दिमाग में काफ़ी सारी चीज़ें रहती है कि अगर उसको कोई पेरीफेरी का मेडिकल कॉलेज मिल गया, सपोज सिंधु दुर्ग एंड ऑल कोकन किनार पट्टी का कोई कॉलेज मिल गया, तो वहाँ पे जाने का कैसे, वहाँ पे रहने का कैसे, फिर फीस भरने से लेके बाकी सारी चीज़ें जो उसके दिमाग में रहती वो सब लेके ना वो 9 बजे क्लास को आता है. 9 बजे जो शुरू में, मतलब फर्स्ट ईयर इज ऑल अबाउट द बिगिनिंग. तो वो जब क्लास में आता है और हम शोएब अख्तर को आगे लाके खड़ा कर देते, चल तू बॉलिंग डाल, और शोएब अख्तर बाउंसर पे बाउंसर डाले जा रहा, बाउंसर पे बाउंसर डाले जा रहा. पीपीटी लगा दिए हम लोगों ने. आई एम नॉट अगेंस्ट द पीपीटी. मेरा बोलना यही है कि आपस में फैकल्टी और जो भी फैकल्टी का ग्रुप है इसमें थोड़ा सा डिस्कस करो, एक दूसरे के साथ शेयर करो आइडियाज़. किसी की आइडिया शेयर करने से अगर कोई टॉपिक सिंप्लीफाई हो सकता है तो उसको सिंप्लीफाई करके बच्चों को थोड़ा सा कॉन्सेप्ट उनके दिमाग में जाए, इतना ही करो, इतना ही बोलना है. ये पूरा प्रेजेंटेशन इज ऑल अबाउट दैट. एंड इन इंस्ट्रक्शन इज लवकरात लवकर खत्म करना है. With that instruction I am giving my this is not lecture, actually this is discussion. So we can make some topics easy, interesting to retain in the mind of the students. So जैसे शुरू में शोएब अख्तर बॉलिंग डालता था, सब बाउंसर जाते थे. एंड वन क्रिकेटर, वन मास्टर ब्लास्टर केम. वो आपको पता है कौन मास्टर ब्लास्टर? ये 2011 वर्ल्ड कप का फोटो है. सो माय आइडिया इज यूज दिस थिंग्स दैट इज कॉल्ड एज मीम्स, फोटोज, GIF, रील्स. जो अभी की पब्लिक जो है वो काफी, इनका पूरा ओरिएंटेशन इसमें ही है. इंस्टाग्राम, हम फेसबुक जनरेशन है, उसके पहले कुछ तो भी आर्कुट था. और इंस्टा हमको समझते नहीं. हाँ हाँ, तो न्यूमोनिक्स यूज करो. न्यूमोनिक्स यूज करने से उनका कुछ हार्म नहीं हो रहा. न्यूमोनिक्स यूज करो, रील्स यूज करो, डायग्राम्स मतलब यूज करो. जैसे एक सिंपल एग्जांपल बताता हूँ. सचिन तेंदुलकर जब भी आता है, अकॉर्डिंग टू हिज हाइट, हिज स्मॉल हाइट, सिर्फ हाइट ना, बाकी सब ऊंचा है. तो इमेजिन जब वेस्ट इंडीज वाले बॉलर बॉलिंग करते थे या पाकिस्तान वाले फास्टर लोग बॉलिंग करते थे, तो सब मतलब ऊपर से जाता था. एंड एट दैट टाइम सचिन तेंदुलकर ओपनर आके, या कभी 1 डाउन, कभी 2 डाउन, कभी 3 डाउन आके छक्के चौके, वो 98 रन की पारी जो पाकिस्तान के खिलाफ खेली, वो कितनी मेमोरेबल पारी है. सो स्मॉल, हाइट कम है. मैं यहाँ पे हाइट पे एम्फेसिस दे रहा हूँ क्योंकि मैं आगे कुछ तो भी बताने वाला हूँ. सभी को पता है. गिव दैट एग्जाम्पल एंड शेयर दैट एग्जाम्पल विथ अवर कलीग ऑल्सो. मतलब नेक्स्ट टाइम वो भी पढ़ाने जाएंगे तो ये एग्जाम्पल नहीं, कोई अपना एग्जाम्पल लगा के बताएंगे वो. सो व्हाट इज इंपॉर्टेंस ऑफ ग्लाइसिन इन द कोलेजन स्ट्रक्चर? And it is smallest, it can occupy the turn and bend in the collagen structure. So that give the strength to the collagen. ये बात अगर आपने बता दी है तो उनको, उसको वो कम से कम 2-3 साल तो नहीं भूलेगा. जब एंट्रेंस का प्रिपरेशन करेगा फिर से आएगा यही टॉपिक पे, और वो अपने दोस्त को बताएगा. इन दैट वे वी कैन मेक द टॉपिक्स इजी. मैं थोड़े रियल टाइम एग्जांपल्स लेके बताने वाला. नेक्स्ट प्ले दिस. ये मैं गाने तो बोलता हूँ बच्चों को क्लास में. So how blood glucose is regulated in our body? It is the tug of war between insulin and glucagon. यहाँ पे बता सकते हम, बराबर है. उनको टग ऑफ वॉर याद रहेगा, स्क्विड गेम याद रहेगा, बराबर याद रहेगा उनको, है ना. इतना इजीली बता सकते हैं. ग्लाइकोजन मेटाबॉलिज्म रेगुलेशन, वो साइकिल्स, वो सब कॉम्प्लिकेटेड है, मतलब इजी है. एक बार अंडरस्टैंड हुआ कि इजी है, दैट कैस्केड. लेकिन अगर उसको फर्स्ट स्ट्रोक में उसको याद रखना है 2 हार्मोन्स, 2 पाथवे, 2 एंजाइम्स एंड 2 स्टेट्स। क्या क्या बोला मैंने? 2 हार्मोन, इंसुलिन ग्लूकागॉन, 2 states, fasting well fed state, again 2 states of the enzyme, phosphorylated and dephosphorylated state of the enzyme is important, and two enzymes, glycogen synthase, glycogen phosphorylase। ये सिर्फ बायोकेमिस्ट्री के लिए नहीं बोल रहा मैं सभी सब्जेक्ट को कोरिलेट करके बता रहा हूँ। तो ये पुल बनाना है हमको, हम फैकल्टीज है आपस में कनेक्टेड है, हमारे ग्रुप्स है, तो एक दूसरे से पूछने से कुछ किसी का बिगड़ता नहीं, और वो बोलते ना नॉलेज हमेशा बढ़ता ही है शेयरिंग से। हाँ, तो ये थोड़ा सा हेल्पफुल रहेगा, ये सब हम डे टू डे लाइफ में यूज भी करते हैं, थोड़ा और ज़्यादा हमको यूज करना पड़ेगा, क्योंकि वो 12th की मेंटेलिटी से वो बच्चा नोट्स पढ़ के फर्स्ट ईयर में एंटर हुआ है, उसको हम बोलेंगे तो मतलब हार्पर पढ़, हार्पर काफ़ी सारी फैकल्टी भी अभी तक हार्पर नहीं पढ़ती है, मतलब अगर फैक्ट देखा जाए तो देर आर, हाँ क्योंकि वो 2-4 लाइन कनेक्टेड रहती, लेकिन इन्फॉर्मेशन बहुत अच्छे तरीके से दिया गया है, लेकिन उसको टाइम लगता है जब तक हमारे पल्ले पड़े हो। नेक्स्ट, हाँ मैं ये पीकेयू में हमेशा ये एग्जांपल बताता हूँ कि ब्लू आइज, फिनाइल कीटोन यूरिया, ब्लू आइज, ब्लू आइज, माउसी ऑर्डर, ये ब्लू आइज उनको ऐश्वर्या राय काफी सारे लोगों का क्रश रही है, तो ऐश्वर्या राय का फेस कभी नहीं भूलेंगे बच्चे। एक बार हमने बता दिया ब्लू आइज, माउसी ऑर्डर, फिर उसके पीछे का रीजन बता दिया, तो वो फिनिल कीटोन यूरिया, इस पे हमारे इसमें एक रोल प्ले किया था हमने, उसमें एक भोंदू बाबा एंड ऑल पूरा रिप्रेजेंट किया था, यूट्यूब पे वो है भी अभी भी रोल प्ले अबाउट द फिनाइल कीटोन यूरिया। उसमें फिर उनको याद रहता है कि माउसी ऑर्डर आता है किस कंपाउंड की वजह से आता है, why there is hypopigmentation, why there is neurological symptoms, and what is treatment to be given। सेम मैट विल फ्लाई, हम न्यूमोनिक बताते हैं 10 इसेंशियल अमीनो एसिड का, मैट विल फ्लाई दे रिमेंबर मैट विल फ्लाई, लेकिन हमको यहाँ पे ये भी बताना है उनको कि टायरोसिन नहीं है, टी मतलब टायरोसिन नहीं है, क्योंकि टायरोसिन बनता है हमारे बॉडी में, टी मतलब अदर दो है, और ए जो है आर्जिनिन, एलेनिन नहीं है, आर्जिनिन है, नहीं तो वो मैट विल फ्लाई में वो हमेशा टायरोसिन बोलेगा, क्योंकि वो टायरोसिन का मेटाबॉलिज्म हमारे सिलेबस में है। नेक्स्ट, चलाओ इसको। हाँ बंद कर दो। एसिड बेस बैलेंस इम्बैलेंस, एसिड बेस का हाउ टू डायग्नोज द मेटाबॉलिक एसिडोसिस, अल्कोलोसिस, रेस्पिरेटरी एसिडोसिस, अल्कोलोसिस एंड कॉम्पेंसेशन। अभी मैं थोड़ा सा फास्ट लेता हूँ। हाँ ये बहुत बढ़िया एग्जाम्पल है। सेकंड मैसेंजर, गर्ल्स हॉस्टल में लड़का नहीं जा सकता, तो वहां पे जो चौकीदार रहता उसको मैसेज, उसके थ्रू एक मैसेज भेजता, सो सेकंड मैसेंजर, तो थोड़ा सा कॉन्सेप्ट उनको इजी हो जाता है। तो मेरा बोलना यही है, यूज दिस सोशल मीडिया, द इमेजेस, GIF, रील्स, मेम्स जो भी अवेलेबल है, जितना भी हम सिंपल कर सके यूज करके पढ़ाया, एक दूसरे को हमने हेल्प किया, तो वी कैन मेक द सब्जेक्ट इंटरेस्टिंग। क्योंकि इसको ऑलरेडी सब लोग बोरिंग, पाथवे और वोलाटाइल सब्जेक्ट है, कितने भी बार पढ़ो भूल जाते, तो with these things we can remember this subject, our student can remember the subject easily. So thank you very much all of you, and thank you very much the team Manipal Tata Medical College for calling me on this dais. Thank you.
Okay.
Thank you,
Please,
sir. Your presentation was truly enlightening as it demonstrated effective ways to teach biochemistry to students in an engaging and fun way. Respected chairperson.
Yeah, just a minute. We want to give an out.
Sir, thank you for the wonderful orientation that how we can make biochemistry simple. Because I was one of the student when you were describing bouncer हो रहा था, मैं अभी भी bouncer लगता है biochemistry मुझे. See, point is well taken, sir. To how far effectively a teacher can do it, left to the development of the teacher, because students are updating themselves. I think with your suggestion, I believe all the teachers should also upgrade themselves a bit, come in touch with the reality and the technology what our students are up to be more relevant in the market. So as a teacher, we should not be outdated. So point well taken. I think we should be a good mix between what we are able to induce these things. I can suggest that these points can add a, see, buzzing, for example, in our lecture, if you are able to add 2 or 3 this type of things in between a class, I believe that's the well balance we can maintain. For every 15 minutes, one such example we are able to incorporate. I think that would be an ideal way of making the class more interesting, because attention span will not go more than 15 minutes. So 15 minutes के बीच में एक लगा है ऐसा, तो I think class will be more interesting. Thank you.
Attention changer types. Yeah, he very correctly said, all your slides were very interesting. The only thing, it has to be in a very fine balance. If you show too much and we have less time, so how fast will you be able to cover up? Yes, and complete your chapter also. अलग अलग एक आध अगर incorporate करे, the relevant ones, only the relevant ones, otherwise, the class will go towards the funnier side.
Sir, the success of your YouTube channel shows that these things are attractive to the students. So if you involve these things, because you are catering to the current students' mindset, I think that's the take-home message we can take, that slightly you can incorporate so that it benefits the students. Thank you, sir. All the best.
Respected chairperson, kindly present a memento to our distinguished speaker as a token of appreciation. I would also like to request our distinguished speaker to felicitate our respected chairperson.
Hope we'll keep up the enthusiasm as we move on to the next session of the day. Next session consists of a panel discussion on Are we ready to prevent diabetes mellitus? Diabetes mellitus is a growing concern in our country, affecting millions of lives. As we strive for better health outcomes, it's crucial to assess our preparedness in preventing this chronic condition. Now I request our coordinator, Dr. Mateen Ahmed Khan, Professor in HOD Biochemistry, LCMCH Palamu, to come forward and conduct the panel discussion. The stage is yours, sir.
So, respected seniors and colleagues, it has been all very exhaustive day, and just to relieve, we have some interactive session, and this is what we are going to do. First of all, I like to acknowledge the expertise and diversity of our panelists who will share their valuable perspectives on this current topic, that is, are we ready to prevent diabetes mellitus? Before we begin, let's set the context. Diabetes affects over 537 million people worldwide, and the numbers projected to rise up to 783 million by 2045. The economic burden and the human suffering and the impact on healthcare systems are staggering. Today we'll explore the prevention aspect of diabetes, examining the latest research, strategies and innovations. So let us start, and our panelists will share the initial thoughts, and then we'll open up the floor for a dynamic discussion. So please join me in welcoming our esteemed panelists. And the panelists are Dr. Naveen Kumar Sinha, the Professor and HOD Netaji Subhash Medical College, Jamshedpur. Then Professor Dr. Sunil Kumar Verma, Professor and HOD Shahid Nirmal Medical College. Earlier, please have a seat over there. And then Dr. Pinaki Saha, sorry, please sir. And then Dr. Sandhya P. Gutia. And then above all, our respected Professor H.L. Murmu sir. Please have a seat, sir. Please. So we'll have, this is 20 minutes. I have been assigned 20 minutes, so we'll try to ask questions one or two questions. First of all, we'll ask one question, and then if the time permit, then we'll repeat the questions. So I've already, do you have any introduction of our teachers? Anyway, I have introduced Dr. Naveen Sinha sir, Dr. Sunil Verma, and Dr. H.L. Murmu sir, and Dr. Sandhya P. Gutia madam is a professor in pathology, HOD, and Dr. Pinaki Saha is from? Okay, KPC Medical College. Fine, thank you. So these are 4 panelists. One is from pathology, and 3 are from biochemistry, and 1 is the senior professor of medicine. I'll just add that Dr. H.L. Marmu has been the professor and HOD of Department of Medicine in Dhanbad, in MGM, and he was a principal of Dumka Medical College as well, and finally he joined over here. So we welcome all you 5, and we'll have a question answer session. So first of all, who is Sir Murmu sir? So your question are, sir, because you are sitting that way, so we'll start from that way. First of all, what are the diabetic prevention programs available at present? Mike, please. Mike, someone, please. So you have been assigned 4 questions, so you'll ask one by one first.
Hello.
Yes, sir.
Well, it's a good question. It is a diabetic prevention program we do have. It is very interesting. Well, in National Diabetic Prevention Program, which has been introduced in the year 2010, and which is continuing still. That is the PP. There's a private as well as the private organization. Those are these people, those who are working for them, and the people, public as well as the private. That is being done. And well, there is a wet reduction, whatever it is, how we'll control this. We do have, if you'll say, the primary and secondary and tertiary prevention. But the primary prevention is very important in the group, those who are risking the diabetes, and they need, and how you will, that mean that you have to control the diabetes, how it is. That they were teaching this people, and they were organizing the program, and that is what we call, it has been approved, that is our National Diabetic Prevention Program, which are still, we are following some of this ring. Well, those who are being given, they are selecting the people there. These are the people, these are the risk factor they do have, and thereby they are being called for, and they are being organized this program, and thereby they are being benefited. And well, they can increase the time being, how long the patient will have. That's the time frame. We can increase that of how long the patient will have this diabetes, how long it will develop this. So we can increase the lifespan of the patient. That's it. Thank you.
Okay, yes, sir. Excellently answered, sir. We are enlightened by your answer. And then subsequently, we'll ask that can a type 2 diabetic patient become euglycemic by lifestyle modification? Because you have discussed the lifestyle modification.
Yeah, but again, a very good question in it. Well, lifestyle modification is a very good point what we do in our day-to-day practice, what we are asking even our patients, those who are coming to us. But here is that how much the person is dedicated towards this lifestyle modification.
Yes, sir. Adherence.
Yeah. And well, when we can bring them euglycemic. Well, here the question arises. Well, that all of you are knowing euglycemic, the normal range of liver.
Yes, sir.
Normal range. Blood sugar. But sometimes what we say, that if you will be asked about the range of the euglycemic, it has been said it is 80 to 180 perhaps, that has been said. But here again we see some of the patients, those who are having euglycemic diabetic ketoacidosis has been seen. That is also
that is interesting, sir. That is interesting.
That is very, sometimes you come across with that. So that's why, so if the person is really sincere about his workout, what is been given to him, then it is our, I think he will be benefited with that. So now we can bring down the, we can be bring the euglycemic can be done with that also. I do agree with you. Thank you.
Yes,
thank you very much.
Thank you very much, sir. So that remains one question left for you. So in the next run, I'll ask.
Okay.
So next, Professor Sunil Kumar Verma, and you have a question, Dr. Sunil Kumar Verma. Can epigenetic profile be a biomarker for a risk prediction of type 2 diabetes mellitus?
Yes, nowadays in the modern era, epigenetic profile can be a biomarker for type 2 diabetes mellitus. There actually the epigenetics, there is heritable changes in the gene without alteration in the DNA.
Yeah.
Now there are various tools which can be used as a epigenetic biomarker. First there is DNA methylation. There are some genes under this like TNX, then PPARG, then there are this PPARG, they are the peroxisome proliferative genes which actually directs or which includes which synthesize about the energy metabolism and glucose metabolism. ABC gene about ATP regarding ATP synthesis gene, and this is related with the fat metabolism. Now TXN gene is there, which is transcription factor related genes. So these genes are related with the glucose metabolism. Now there are some other genes like FTO genes, which is related with the obesity. Then there is gene like INX that is for, and there are some other genes which can be used as a biomarker where there is changes in methylation. Now second thing is the modification of histones, where there are methylation as well as acetylation. They can be used as a biomarker because there are also some genes are there in this which we can use them. Then there are some epigenetic clock, like which is known as Howard's clock. There are changes in the methylation that is calculated, and that can guide to the aging of the tissues, and this is used also as a biomarker. Then nowadays microRNA that has been used regularly. They used to do the silencing of the gene.
Yes.
microRNA 143, microRNA 145, then microRNA 375. They have been used in the case of related to the type 2 diabetes mellitus. So all this, taking all this, we can use them as a tool. But there are challenges. Challenges are they must be standardized, there must be validation, and there must be interaction with the current or biomarkers. So they must be interacted in this way. These are the challenges, but in future, these are a good tool which will help us to tell us about the risk factors, and we can use them in the personalized medicine.
Yes, today we discuss.
And this is a future scope, so now it has a greater scope in the case of type 2 diabetes mellitus markers.
Excellently done, though very, very, lucid and very tough kind of words used. But yes, genetics, the progress in genetics has been so much, so enormous that it takes time to even learn about those words. And why and at all you have been asked, because I know Dr. Sunil Verma is not only a professor, but he has done PG diploma in genetics as well from Sanjay Gandhi Institute, Lucknow. And we both have graduated from the same college. That's why we know each other more. So thank you, Dr. Sunil. And now the question goes to Dr. Pinaki Saha. Sinha or Saha, sorry, extremely Saha. Is it a myth, Dr. Saha, is it a myth? Type 2 diabetes patients don't need insulin?
No. Previously it was a myth that type 1, we give insulin to type 1, and coming to the pathophysiology, the type 1 patients suffer from insulin deficiency. But nowadays, in many situations, we have to switch over to insulin, mainly initially if the patient presents with very high blood glucose and the glycated hemoglobin level is very high, then initially we can bring down the blood glucose level with insulin and then switch over to oral secretagogues. Otherwise, to decrease the macro and microvascular complications, we can use this insulin, and nowadays clinicians are using insulin just after starting, keeping the patient for 1 or 2 years with oral hypoglycemic agents and then switch over to insulin. Because in studies like UKPDS, there they have come up with an idea that previously we used to say that keep the HbA1c below 7. That will improve the patient's health as well as decrease the micro and macrovascular complications. But nowadays, if they are advocating that you prescribe insulin so that this HbA1c level is below 6.5, that will prevent complications more. And so now it is not a myth.
Okay, so excellently done again. And because many of our diabetes 2 patients, when we prescribe insulin, then they say kahin aadat to nahi pad jayegi, and that's why most of them actually avoid insulin. So that's a great knowledge. And now, thank you. And now the next question goes to Professor Naveen Sinha sir. The first is diabetes 2 mellitus curable?
Type 2 diabetes is not curable. It can be controlled, and controlled by number 1, lifestyle modification. The lifestyle modification means diet is number 1, number 2, regular exercises, weight loss. These are the things by which we can control. Some bariatric surgery, also the control or of diabetes type 2. So we have to, lifestyle modification is one of the important.
Yes. I'll tell you that non-communicable diseases, usually we actually the cure is a philosophical word. I say that. Cure has many definitions. Like there is a cure model, there is a remission model. Then in communicable diseases, there are different models. But in non-communicable, yes, you told that it is controlled and until it's not curable. So now the next question goes to Professor Sandhya. And madam, your question is 2, so you can answer in part, first part, and maybe in the second round will come, and then you can. The question is 1, but this has 2 parts. The role of pathologist in early detection and prevention of complications of diabetes mellitus. So you can answer 1 part or maybe both. Then I'll have another question for you.
So as we know, we have basically we divide the complications into 2 groups. The long-term complications are microvascular and macrovascular complications. So macrovascular complications, usually it's myocardial infarction, involvement of the cerebral vasculature and peripheral blood vessels. And microvascular complications are the diabetic retinopathy, diabetic neuropathy, and diabetic nephropathy. So we have certain markers which actually detect the early onset of these complications of type 2 diabetes mellitus. So when we talk about diabetic nephropathy, one of the very earliest markers is detection of microalbuminuria.
Yes.
So this microalbuminuria, it is the very early stages, like even before the diabetic nephropathy can be detected. So if we detect microalbuminuria, we can reverse nephropathy at this stage. So detection of around 30 to 300 milligrams per day of albumin is termed as microalbuminuria. It is it's not possible to detect this microalbuminuria by the routine testing, so we have to go for the special test, either nephrolometry or chemiluminescence. The other markers which help in the detection of diabetic nephropathy at the early stages is we can use cystatin C, which is considered as a more sensitive marker than creatinine in the determination of glomerular filtration rate.
Yes, yes, please continue.
Okay. So, okay, now when we talk about the various cardiovascular markers that actually help prevent the adverse events in cases of type 2 diabetes mellitus, one of them is a high sensitivity C-reactive protein.
Yes.
So normally we are doing the C-reactive protein, which is actually an acute phase reactant produced by the liver, and it is an indicator of acute inflammation. Because diabetes mellitus has chronic low-grade inflammation as one of its pathophysiology, we can detect high sensitivity C-reactive protein, which is an early indicator of heart failure also, and even before the development of diabetic cardiomyopathy. The other markers which detect the nephropathy, it could be kidney injury molecule 1. There is a very important molecule that helps us to detect the tubular injury and the tubulointerstitial disease that is produced by diabetes. I should talk about the other markers also, right?
So the next part is prevention. So probably when we come again, then you'll be able to answer. If you choose to answer, then I'll definitely ask a different question. Maybe. Okay, you just complete. You complete your second part, yeah. Prevention, yeah.
Okay.
Now you have talked about, now you talk about the prevention also.
Okay, so we have other important novel biomarkers like advanced glycosylation end products. These AGS products, they are actually formed as a result of when the glucose, it binds to various proteins and amino acids and the lipids in the body. So these basically, these AGs, they actually go and they bind to the basement membrane, and they actually result in the development of diabetic retinopathy and diabetic neuropathy. So determining the levels of these AGs, actually it helps us to tell initially whether the patient is going into these complications or not. So very low levels, actually they tell us that patient still has not progressed into these long-term complications. Another is we can detect the levels of C-peptide also.
Okay.
So studies have shown that the C-peptide levels, they are secreted in equimolar concentration like that of insulin. But C-peptide is actually more sensitive, and it is a better marker because its levels are not influenced by the by the exogenous insulin as well as the stress levels as well as any meal that is taken. So it helps actually to maintain the glycemic control and tells us about the endogenous release of insulin. So patients who are having type 2 diabetes mellitus, they'll have very high levels of C-peptide.
So very well spoken, madam. Actually now we know that at least there are some markers through which we can know how the disease is progressing and we can halt it. So now thank you for that. And now again second round question goes to Dr. H.L. Murmu sir.
Hello.
Yes, ma'am, please. Give a mic. Just.
So, with a very layman's background, I want to say, being a biochemist, of course, but we have to be very, very cautious while we say what tests to be done and what tests not to be done, sir. Like, we have to be very, very, supposing somebody has diabetes in the family, sir, and we just can't go on and on telling the tests one after the other. Even our AIMS Delhi practicing doctor first advises for fasting and postprandial, and if that is very difficult, of course, in a normal setup, random, he will ask तुम्हारा blood sugar कितना था. Then he will ask for glycated hemoglobin, which I feel, sir, is the best marker for a, मतलब वो patient आता है and he first asks what is, and gets it done, glycated hemoglobin. अगर glycated hemoglobin गड़बड़ है, he will definitely prescribe medicine, मतलब as a practicing ये. And of course she told a very good ये is microalbumin, कि kidney खराब हो रही है तुम्हारी, आँख में problem है, वो आगे level पे जाएगा. And as a routine, as a patient, at home, and we have to be very cautious कि क्या advise करे क्या नहीं करे. And I feel glycated hemoglobin stands the test of time with random blood glucose level.
Yes, thank you, madam, for your.
घर में किसी को है तो we become very cautious कि क्या कराना है और क्या नहीं कराना है.
Yes, ma'am.
Not in the research purpose. I'm telling in a practicing.
Yeah, ma'am. That's correct. So it's a second and last round, and the question goes to Murmu sir, and the question is how frequently and how long the person should be monitored for recurrence of diabetes mellitus after he becomes normoglycemic or euglycemic.
Well, again, it is a very good question indeed. Well, some certain things are there, clinician to clinician, it varies sometimes in the book, and well, several houses there, one is Jocelyn Diabetic, American Diabetic Association, they do have their own here. But here it is very interesting part what we see here. Well, if the patient is having, if the patient is euglycemic, here would, initially what we do, 2 to 3 weeks, we go for a routine examination, whatever the blood sugar, what is the and well, it will be continued for first 6 months, and then another 6 months, that will be after 3 months or 3 likewise, and that will be concluded that will be continued as for 4 to 5 years. That is the way. So that is very interesting part of the patient. And well, the question that she has asked, there's a very interesting part. If I will be allowed to speak out of the question,
please.
Well, the goal marker,
the
goal markers of this HbA1c, that is a very important. What we see now in the day-to-day practice, in our practice, whatever we are getting, good number of cases of diabetes mellitus of type 2. And well, in that, what we have seen, the most of the patients, they are coming with the level of 12, 15, even like this. So most of the very first time, if you are getting, they are coming with a 10 and all. So here it is very interesting, whether what to do, what not. The blood sugar will go, blood sugar, fasting PP, that will give you the whether you will start the insulin or not. But well, the interesting part is that HbA1c or A1c, what we do, that will give you the 3 months of the label, what it is coming at that. That is the important point. That's why we do. She is very rightly, she had very rightly, doctor asked, that is very interesting part. The HbA1c is the marker by which you can, whether we start insulin or not. Because once the high blood glucose is gone up, suppose 500, 600, that's the only way is to start is the insulin. It doesn't mean that insulin will be oral hypoglycemic drug. Here is the myth that most of the patients, they are coming with that as a command, I will be given insulin. But what it is that? Well, insulin, once you will control the blood sugar, then you can come over to again oral hypoglycemic. Thank you.
Okay,
thank you very much.
Thank you very much, sir. Actually, HbA1c actually has to be seen with some caution, and that has to, because it is a part of adult hemoglobin, and once somebody is having severe anemia, then probably there will have to do something, some with caution. So it's okay, fine. Thank you, sir and madam both, for enlightening us. And now question goes to Sunil, and that's your last question. How important are environmental factors for risk prediction? Probably you'll be answering more. Yeah. Environmental factors.
Really, environmental factors plays a role, great role, because if we go for the 35% of monozygotic twins, they are identical twins, they suffer from diabetes mellitus.
Oh.
That means if genetics plays the only part, then 100%, there must be 100%.
Yeah,
And most of the time we curse our parents ke always we ask कि आपका father को था and mother को था, but father contribute 9%, mother only 3%. If both of them are diabetic, then 30% is chance of getting diabetes in the children. So don't curse your parents कि हाँ उनको था तो हमको भी होगा. So environmental factor plays a great role here.
Yeah, very good.
Naturally, everybody knows कि diet is the main concern today. We are now our lifestyle have changed. We are going for Western diet. So foods which are not to be taken. Earlier, पहले हम लोग जो खाते थे, they were the healthy foods. आज के दिन में adulteration is there. Moreover, less fiber we are taking, and all those fast foods, these all contribute to the type 2 diabetes mellitus. क्या sir? हाँ sir, that truncal obesity, we Indians are more predisposed for truncal obesity.
Yes.
So,
Asians
BMI is more than 30, then it is obese. But in our, in Indian
Context.
countries, this is for foreign context, sir. We are reading the books of written by the foreign authors.
Authors.
In Indian context, it is, if it is more than 25, we are obese. So we must take care if our BMI is exceeds 25.
Yes.
Next, truncal obesity. If our circumference of abdomen is more than 100 centimeter for male and 90 for female, then we must be get concerned to lose our truncal fat. That causes great, that is more predisposed for type 2 diabetes. Physical inactivity. So physical inactivity is very important. Unless and until we are engaged in physical exercise, we will be predisposed for type 2. Then fatty liver, fat कम कीजिएगा sir तो fatty liver
Okay.
कम हो जाएगा.
Okay,
Then
okay.
there are also some sleep is very important,
Yes.
which we are ignoring nowadays.
Yes.
Stress, that
Stress,
I am coming.
So the
Stress,
lifestyle, our lifestyle has become such.
stress is important. Sleep time, circadian rhythm is very important. If somebody nowadays youngsters are going to sleep by 2 p.m. पहले के दिन में सर 10-11 बजे अर्ली टू बेड अर्ली टू राइज. स्टिल हमारे हिंदू कल्चर में ब्रह्म मुहूर्त में उठने के लिए कहता है, एंड दैट इज बेस्ट एज फार एज साइंस इज ऑल्सो कंसर्न. सो sleep time and inadequate sleep leads to the type 2 diabetes mellitus. Stress leads to the type 2 diabetes mellitus. Socioeconomic status. Poor socioeconomic status also leads to the inadequate food. Food, and in our context, suppose omega-3 fatty acids should be taken. So we must take good quality of food. That is important. So all these things will pollution, air pollutions, and there are many toxins which are present here in many chemicals, which also lead to the predisposes us for the type 2 diabetes mellitus.
So I guess that have answered the audience questions query. Yeah. Thank you, Dr. Sunil. And now we move to Dr. Naveen Sinha, sir. And your question is, what are the criteria? Probably this is, madam was, this should have been the first one, the question. What are the criteria for early screening of diabetes? What are the biomarkers used for screening?
Early screening of type 2 diabetes, we have to see the risk factor. That is, number 1 is over 45 years of age. Number 2 is obesity. Third is, as Sunil told, that is sedentary lifestyle. Fourth is hypertension, genetic, and hyperlipidemia also.
Hyperlipidemia.
Yes. So these are the risk factors, and the screening test, that is fasting blood glucose level, that should not be 126 milligram per dl, and the glucose tolerance test, oral glucose tolerance test also, and third is HbA1c. These things are basically important. Then there are so many tests, but these 3 tests are important for screening.
Okay. Thank you, sir. And now the question to Dr. Pinaki Sahad. Again, you have a question on insulin and diabetes.
Okay.
So scientific reason and explanation for role of insulin in this type 2 diabetes mellitus.
First, we have to understand that in type 2 diabetes mellitus, there is a block at the receptor level or post-receptor level, not directly an insult to the beta cells. But initially what we find is that the level of insulin in the patient is quite adequate. But the effect of the insulin is not there. So he is suffering from diabetes and hyperglycemia. But later on, as days passed, the level of insulin drops. This can be assayed. The endogenous insulin can be assayed by C-peptide.
Yeah.
And if we switch, many of the clinicians now give the exogenous insulin, either in the long-acting form or the short-acting form, along with the secretagogues. And of course, in case of obese patient, they prefer metformin. But if we want to differentiate between these two, that endogenous insulin and endogenous insulin and exogenous insulin. Endogenous insulin level can be assayed by C-peptide. Exogenous insulin is the outside insulin which we are giving. The thing is that after some years, after few years, the body is unresponsible. The cells are unresponsible to the insulin, endogenous insulin, but they are responsive to this new insulin, that is the exogenous insulin, unless and until the insulin resistance develops. So this is why after few years, 2-3 years, the clinicians advocate the use of exogenous insulin, and that helps again in the reduction of the morbidity as well as mortality in case of type 2 diabetes. And in case of insulin resistance, if the need of insulin is increased, then there are some other drugs which have come up, like the glitazones, so to modify that level. So this is the utility of giving insulin in case of type 2 diabetes. And in some other complications like diabetic ketoacidosis is more associated with type 1. In type 2, sometimes we have faced some decay, diabetic ketoacidosis. There also we have to use insulin. And in case of emergency surgery, we have to reduce the blood glucose level. So there also we give insulin. Even many of the clinicians, they prefer, while in the critical care unit, they give the sliding scale of insulin. Uske baad, they frame a fixed dose with regular insulin and long-acting insulin.
Thank you. And now for you, madam, pick up one question of your own, madam. This is your choice, and say, and enlighten us relating to pathology and diabetes mellitus. Yes, sir. It's all your choice. Just we had question. Yes. So nephropathy and diabetes, fine.
So when we talk about diabetic nephropathy, the main pathogenesis is the formation of the advanced glycosylation end products, which result in the cross-linking of the different types of collagen, particularly the collagen 1 and the collagen 4 in the basement membrane. Along with that, what happens, there are two important pathological features in the glomeruli. That is, there is thickening of the basement membrane, that is known as diffuse diabetic glomerulosclerosis.
Excellent. So we now come to conclusion of this enlightening session, and the topic was, are we ready to prevent hypertension? So I'll ask you to raise how many of you will really want to prevent diabetes mellitus. Raise your hands, please. I guess the whole house. Even if those who are suffering from. So they'll yes. Yes, sir, please. Yes, sir. And you did not. So again. Yes, beverages do have a lot of. And yes, we Exactly. Meetha. लेकिन सर मीठा बोलेंगे. जी. So we anything Sunil want to conclude something? So any of you, sir, any of you want to say anything? Our distinguished guests, please, sir. Yes. So thank you very much, all our guests and our listeners. Thank you very much, and thank you very much to Madam Sunita and the organization who gave me an opportunity to speak before you. Thank you very much. We had a very enlightening and very entertaining session. Thank you.
Thank you, sir. As we conclude, as we conclude this panel discussion, we appreciate the collective wisdom shared by our experts. Your participation has been instrumental in advancing our understanding of diabetes prevention. Thank you again for your thought-provoking insights. I would now request Dr. Lakshman Lal sir to hand over the token of appreciation to Dr. Matin and all the panelists. Thank you, sir. I now request Dr. Jambulkar to please join in appreciating our panelists.
क्या सुनाना है? In 7 years, I have purposely written 3 chapters. One is diabetes, another is obesity, and third is a day in ICU, waiting to die or recover. So this critical treatment of ICU is becoming monstrous. नर पिशाच लोग मानव शरीर का अंत करते हैं, नोच के खाते हैं, उसके परिवार के पास जितना भी पैसा है, रिसोर्सेज है, पायल और बिछिया तक बंधक हो जाता है और डेड बॉडी घर आता है। ऐसी पीड़ादायक स्थिति में मैं भोग चुका हूँ। मेरी मदर इन लॉ 41 दिन पटना के पारस हॉस्पिटल में आईसीयू में भर्ती रहीं। 40 लाख का करीब बिल आया। मेरी वाइफ, 6 भाई बहन, सब लोगों ने लगा, सबके मन में एक ही बात थी कि मम्मी आ जाती घर, एक बार आंख खोल के हम लोग को आशीर्वाद दे देती। उसी इमोशंस को वहाँ पर पूरा कैपिटलाइज किया और कॉरपोरेट हॉस्पिटल ने उनका भक्षण किया। और हम हर एक हफ्ता में 2 बार पटना जाते थे। 1 साल उससे पहले मेरे पास रहीं, हमने उनका केयर किया, सब कुछ। और क्या है आईसीयू ट्रीटमेंट? आईसीयू ट्रीटमेंट सोवेनियर में इसीलिए मैंने दिया कि हो सकता है मुझे बोलने का अवसर नहीं मिले। ये आईसीयू का मैनेजमेंट एक आर्ट है, एक बहुमूल्य जीवन को बचाने का लक्ष्य है। एक परिवार के अंदर का जो इमोशन है उसको एक्सप्लॉइट नहीं करके सेवा भाव से देख लेना है। मैंने अपने बेटे से, अपनी वाइफ से कहा कि मुझे कभी भी लाइफ सपोर्ट सिस्टम में नहीं रखना, कभी भी मैं वहाँ नहीं जाऊँगा। मेरे ऊपर जो खर्च होगा मेरे ग्रैंड चाइल्ड के लिए एफडी कर देना। हमको let me die peacefully, let me die peacefully. I had been a happy person in my life, everywhere, my childhood, my schooling, my medical college duration, my job, everything. I led a window. I don't want a dreadful death. I want a peaceful death. So, what to do? If your near and dear is in ICU, what the ICU should, first and foremost thing is, the physiological score of that very individual should be assessed. The 12 parameters, that has to be assessed on the first day of admission. Then, you are monitoring, you are doing everything, watching ABG, watching all parameters, everything, giving treatment, intervention, even mechanical support, tracheostomy, everything is being done. For what for? Are you confident of recovery of that poor patient? Are you confident of providing quality care to the patient? Are you? My younger sister, my own younger sister, she was having diabetic nephropathy. आईसीयू में भर्ती हुई और क्रिएटिनिन 4-5 था, पोटेशियम 4-5 था, डायलिसिस हुआ। स्टेंट बनाने के लिए, शंट बनाने के लिए पूरा हॉस्पिटल जो था लालायित था, रखा। She died painfully. my father, he was admitted in Ruby Hall, Pune, and he remained there for 15 days. With quality care of Ruby Hall, Pune, my father came back to home, stayed there with the family. All of us, we joined there. Again, he had problem. Went to Ruby Hall ICU again. On 2004 Janmashtami day, my father caught hold of my mother's sari and said, हमको बहुत कष्ट हो रहा है, आपका पुण्य हमको जाने नहीं दे रहा है, सब बाल बच्चा को बुलाइए, हमको अनुमति दीजिए। जन्माष्टमी के दिन 2004 में मेरे फादर लास्ट ब्रेथ लिए। तो ये हम सब इस बात को समझें कि क्या आईसीयू कॉर्पोरेट हॉस्पिटल का मनी मिंटिंग मशीन है, ह्यूमन सेंटिमेंट को एक्सप्लॉइट करने का मशीन है, केयर करने का मशीन है, क्या है? पूरे परिवार का पूरा पैसा चला जाता है, भाई भाई में हॉस्पिटल का बिल पे करने के लिए झगड़ा झंझट होता है, सबकी वाइफ एक दूसरे का बाल खींचती है, सब कुछ करती है, प्रे करती है कि जल्दी से जल्दी बूढ़ा बूढ़ी जल जाए, समझे ना? तो करना क्या है? करना क्या है? जो हीरा करता था एमजीएम का उस आर्काइक आईसीयू में, आज प्रोफेसर एचओडी ऑफ मेडिसिन, आईसीयू में उतना गरीब नंगा सब आया, 3 दिन में उसको रिकवर करा दिया, सारा उसका वाइटल्स ठीक हो गया, वेंटिलेटर का जरूरत नहीं पड़ा, वो घर गया। तो ये जब मेरा दोस्त कर सकता है, मेरा क्लासमेट कर सकता है विथ लिमिटेड रिसोर्सेज एक गवर्नमेंट हॉस्पिटल में, तो विथ इनॉर्मस हु कैन डू दिस? सो वी विल गो फॉर फिजियोलॉजिकल स्कोरिंग, ग्लासगो कोमा स्केलिंग, then CAM ICU, then assessment, then sequential organ failure assessment. Then we should see the data, the artificial intelligence should be there. What is the prediction for survival? How much they are going to see the day when that poor body will go back to the crematorium. So, with folded hand, with all my emotions, I request you all that we should, as a biochemistry people, because all ICU management, be it ABG, be it lab test, be it anything, respiration, acid-base balance, everything is ours. Anesthetist or physician, they come next. So, as a biochemist, just see, just visualize, manveti pashyati sochayati iti manushya. A man is that who thinks, who sees, and who broods. So, my dear friends, with folded hands and my respect to my departed souls, thank you.
I request Sinha sir to hand over the momentum.
Good evening, respected dignitaries, esteemed speakers, dear colleagues and valued guests. I'm Dr. Soumya, tutor, Department of Biochemistry. It is both an honor and privilege to stand here today as we come to the conclusion of the Eastern Zone Association of Clinical Biochemists of India Conference 2024. I stand before you to reflect on the incredible journey we have shared over the past 2 days. As the field of biochemistry continues to evolve, we find ourselves at the crossroads of science and technology, where advancements are reshaping labs and revolutionizing healthcare as a whole. The discussions we had here illuminated the critical role diagnostic biochemistry plays in early detection, accurate diagnosis, and the overall improvement of patient outcomes. I would like to extend heartfelt thanks to the Department of Biochemistry at Manipal Tata Medical College and Department of Biochemistry at Mahatma Gandhi Memorial Medical College and Hospital, Jamshedpur, for their tireless efforts in organizing this event. Without your dedication and seamless coordination, this conference would not have been possible. Our theme, Advancements in Diagnostic Biochemistry, Shaping the Future of Healthcare, which was showcased in a beautiful manner by Dr. Prakriti Das, has not only guided our discussions but also highlighted the ongoing evolution in our field. To our speakers and panelists, your expertise has enlightened us, bringing forth the latest research and breakthroughs that have opened new avenues of thoughts. From the in-depth sessions on next-generation sequencing by Dr. Senthil Kumar and electives in biochemistry by Dr. Sulekha Sinha, to critical discussions on sickle cell anemia by Dr. Pradeep Kumar Patra and biomarkers for preeclampsia, your insights have been invaluable. We explored menopause and coronary artery diseases in women through Dr. Jayashree Bhattacharya's presentation, as well as innovative approaches by Dr. Rajesh Jambulkar in making biochemistry more engaging for students. These discussions, combined with the focus on the role of biochemists in managing multi-organ failure by Dr. Lakshman Lal, have laid a solid foundation for future explorations in diagnostic biochemistry. We also witnessed some remarkable presentations by our delegates, faculty members, and postgraduate students, which enriched the learning experience for all. So now we'd like to proceed with the prize distribution ceremony. The first category, which was Health Sciences by postgraduates. To felicitate the winners, I'd like to call Dr. Hiralal Murmu sir, HOD Professor, Department of Medicine, MTMC Jamshedpur, to come on the dais. The consolation prize for this session goes to Dr. Sonam Sarita. The third prize goes to Dr. Utsav Haldar. The second prize goes to Dr. Twinkle Krishna. And the first prize goes to Mr. Moneet Sundrial. Thank you so much, sir. Now we move forward to the next category, Health Sciences by faculties. The third position goes to Dr. Hirok Chakravarti. Second position goes to Dr. Nagamati. And the first position goes to Dr. Manaswini Panda. To Thank you so much, ma'am. For the next category, oh, sorry, ma'am. For the next category, medical education, I'd like to call Dr. N.K. Sinha sir, Professor Biochemistry, NSMC Jamshedpur, to felicitate the winners. The third prize goes to Dr. Chinmay Das sir. The second prize goes to Dr. Swikriti Behra ma'am. And the first prize goes to Dr. Sulekha Sinha ma'am. The third prize goes to Dr. Chinmay Das sir. The second prize goes to Dr. Swikriti Behra ma'am. And the first prize goes to Dr. Sulekha Sinha ma'am. Thank you so much, sir. Before I conclude, I would like to express my deepest gratitude to every one of you who participated in this event. Your enthusiasm and commitment have been truly inspiring. As we close this conference, let us carry forward the knowledge we have gained and the connections we have forged. Together, we can transform ideas into action and shape the future of our field. Thank you for your contributions, and I look forward to our collective journey ahead. Thank you, everyone. Now I'd like to request Dr. Kavita Rasalkar, Professor HOD, Department of Biochemistry, MTMC, to come on to the dais to extend the vote of thanks.
I'm sure nobody is interested in this long vote of thanks, so I'll just start with thanking Lakshman sir, Rajiv Ranjan Sinha sir, N.K. Sinha sir, Murmu sir, Vinod sir, sir का नाम नहीं पता, Verma sir, हाँ Verma sir, Pinaki sir, and Vanita Lal madam, Arvind sir, Jumbalkar sir, everybody, each and everybody. And during my morning vote of thanks, few things were missed out. The thank you for Mr. Ankur, please come. Sir Bharat and team. Kavita, Kavita.
सर को डेडिकेट कर रहे हैं। रहे ना रहे हम महका करेंगे, बन के कली बन के सवा बागे यहाँ पे, रहे ना रहे हम।
पास बैठो तबीयत बहल जाएगी, मौत भी आ गई हो तो टल जाएगी। चलो
नहीं पता सर। छोटा मोमेंटो है, प्लीज आइए। अरे वाह, रुको तुम सर का गाना गाने दो उनको पहले, अब हम देख लेंगे गाना। कौन सा
क्या लड़की हो जी?
अरे हम सब बन गए सर।
बहुत बदमाश हो बचपन से।
सही बोले सर, बचपन से सही है।
पास बैठो तबीयत बहल जाएगी, मौत भी आ गई हो तो टल जाएगी।
उसके बाद सर गाना क्या है इसका, उसका हाउ डू यू सिंग द ये पैराग्राफ? धार काजल की तुम और तीखी करो। अच्छा पास।
Now I request Asmita to sing a song, our MC for the first session. Please Asmita, Sir, we have few singers with us. Any other students?
नहीं मेरे लिए नहीं, रुकिए, अब वो वाला हाँ समझ में आ रहा, आपको क्या समझ में आएगा? अच्छा ओके
ओ सजना बरखा बहार आई, रस की पुहार लाई, अखियों में प्यार लाई। ओ सजना तुमको पुकारे मेरे मन का पपीहरा, तुमको पुकारे मेरे मन का पपीहरा, मीठी मीठी आंगनी में जले मोरा जियरा। ओ सजना बरखा बहार आई, रस की पुहार लाई, अखियों में प्यार लाई। ओ सजना
Anybody? Youngsters? तुम लोगों में से कोई गाती हो? Anybody? हाँ? नहीं?
हाँ 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 हाई टी में ये है सर, हाई टी में अभी देरी है, तो एक गजल है जो जगजीत सिंह का है, इरशाद बोलिए सर। बाप रे बाप, उतना नहीं हम जानते हैं आपके जितना। So this is a ghazal from Jagjit Singh and Chitra, all of our favorite. दुनिया जिसे कहते हैं जादू का खिलौना है, दुनिया 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 जिसे कहते हैं जादू का खिलौना है, मिल जाए तो मिट्टी है, मिल जाए तो मिट्टी है, खो जाए तो सोना बरसात का बादल तो दीवाना है क्या जाने, किस राह से बचना है, किस राह से बचना है, किस छत को भिगोना है,